There have been a couple different ways that I have seen a perineal exam get done. So one of them is once the mama has delivered and the placenta came out, she went in and took a shower. They've had their golden hour. We come in there and do a exam right before she does the peri bottle and puts a pad on. Or as soon as the placenta comes out, since you're there already, you can do an exam right there and then, which I really like that idea. I've only seen that done recently, and I think it's great. But I guess it depends on the mom, like if there's been issues and she needs to, just have some time on her own before we get going on the exam, because not a lot of moms like it, or nobody likes it for that matter. Anyway, so for the exam, what you would need is a pair of gloves, some gauze, and a headlamp or a really bright flashlight. And we also like to spray numb before we do anything, just because everything is super sensitive, it's swollen, and moms are already in pain after just delivering. So we like to numb it up a little bit, make sure our light is bright enough, and then position the mom where it's comfortable for her, and then you as the provider can sit and visualize everything. So a lot of times if the mom has delivered on the bed, or you would bring her on the bed after she's delivered, like in the water or on hands and knees, you would lay her down and have her put her feet together and bring them up, bend her knees, and then let them fall apart. And sometimes we even need to put something underneath her bottom just to have something even, so her bottom's not falling into the bed and we can see better. Something like a cutting board or a cookie sheet or something of that sort. Anyways, so we'll use our gauze and we'll start from the top all the way to the bottom, and then from the inside to the outside. And what we're looking for is any laceration or cuts or tears that don't really fall apart and they're bigger. So sometimes there's something like a split lip, and if it falls together, then we tend to leave it. Not a lot of moms want to get that sutured. They're fine leaving it, but if it's like a second degree tear, we recommend that they get that fixed. And we check if the vaginal wall has any tearing. We'll go deeper into the muscles and make sure the perineal is fine and there's no any tearing. And then if there is tearing, we explain to the mom what degree the tearing is, and how everything is going to be laid out. So the degree of the lacerations is first degree. The first degree, and it involves the skin, the vaginal mucosa, and then the second degree involves the skin, vaginal mucosa, and goes a little bit deeper into the perineal body and the muscles, but not all the way down to the anal sphincter. That is more of a third degree tear, and then fourth degree tear, which I have never seen that done. I know that the preceptors that I have worked with and the midwives that I have assisted, they've all said that they transfer for third degree tears and fourth degree tears. So so the instruments that we would need to suture is, I can show some of this stuff too. So we need sterile gloves, and we use the sterile gloves, the packaging for it, as our sterile field. Scissors, needle holders, and mustaches. We need our suturing thing, and just depending on what kind of suture we need. So the larger gauge needle, like the 406080, it's a finer suture, so you would use that for like the first degree tear, something that's on top, and then the smaller gauge, something that's 2.0 or 1.0, is a more thicker, more stronger suture, and that's used more for the muscles. And the 3.0, so 3, 2, 1, that's used for second degree. I only have this one. That's the one I practice with. And then what I really will be suturing with is like a fake suture that I've gotten to practice with. anyways, so after we inspect it, we make a plan, we make sure the client is on board, we talk to her about what's going to happen, what we need her to do, and then we set up our equipment. So we'll start off with like I don't know if you can see that, but we have all of our stuff here. We'll have a bunch of gauze because we're going to need it. My preceptor uses this solution to clean off. So before she starts anything, she'll numb spray them, and then she'll use gauze and this to clean everything off to see where the most bleeding is at. And then after that, she will do the numbing. And so then when she draws up the numbing, we have a sterile bottle that has a filter needle in it, or just a needle in it, and then a syringe. And this is my syringe for the flash. That I'll have another needle on there. And so when I'm drawing up, I'll use the needle that's already in the bottle and draw up, and then leave that needle there, don't take it out, and screw on another needle into the syringe. And before she pokes anything or prods anything, she sprays it. So she'll take the syringe and she'll just spray it up and down on the vagina and the perineal to kind of help with the numbing. And then she'll start inserting the numbing medication. And after the numbing medication, she'll open her sterile field. So she uses these gloves. I don't want to open them, but she'll use these gloves, and she'll take this paper right here, and she'll put that as her sterile field. And over there, she'll use her instruments. So she'll put her instruments on there and her suturing stuff on there. Let's see where we're at. Oh, and then of course she needs a light and a cutting board or a cookie sheet underneath the mom's bottom with legs like sitting. So if the mom is on the edge of the bed, like let's see, the mom is right here. This is my pelvis facing me right here. She would need like a stool or maybe her support system or myself, or she could put her feet, and then you're suturing right here. So her bottom's kind of falling out. And then sometimes my preceptor either tucks the sterile field underneath her bottom, or she'll keep it in her lap. And then she has something to work with, and she has a lamp on her head for the light too. Put this over here. Okay, so once the numbing is done, we will start our laceration. So I kind of got this started. This is my practicing foam thing. I don't know if you can see it. But see, it's right here. I already started, and I did an anchor stitch right there. And usually the anchor stitch is a little bit above where the suture needs to be, where the suture needs to start. And then over here, it's just a straight cut, like right here. It's just a straight cut. So we would do continuous suturing. And my hands would have sterile gloves on them. And I would take my needle holder and attach it like this. And I will insert it on one side and come out on the other side. Let go of it with the needle holder, grab it from the other side, and pull. And then do the same thing again. I'm sorry, it's kind of hard to see. I need a GoPro on my forehead. And we'll do one more. And I'll put this in here so I can kind of show you what I worked with on the back side. So the back side, I have some examples of what I did that one I messed up. But this is the muscular suture that goes inside. There you can kind of see it, the continuous one. And then I have interrupted right there with knots that you can do. So the whole time that we're suturing, we're talking to the mom kind of to get her attention off what's happening and making sure that she's feeling okay and not passing out on us. So we explain everything to her, before we start anything where you'll feel a slight touch. I'm sorry, I know this is not very pleasant. I will make sure this exam goes by quickly. I'll make sure that we're suturing as fast as we can. And when I do the exam, I'll tell her exactly what I see. I'm starting at the top of your vagina, just looking for everything is intact over there. I'll work my way down. Let me know if you need me to stop or if you need me to take a minute, if you're still doing okay, if you need more spray numbing stuff. And then let's say that it's a 2nd degree tear, and normally we recommend that it gets done. We'll say something like 2nd degree tears, our standard of care is recommending a repair since the muscle integrity is impacted with the tear, and of its depth. But you can also opt out or decline, and these are some of your options. I've heard of like clips. I've seen my preceptor, she has tape, like little pieces of, I don't even know, I've never seen her do that. But she said she's only had to use that once. And then some of our moms, the ones that are supernatural, they don't want anything, they'll use seaweed, which that will tell them to use if it's just like a split lip, we'll tell them to use a piece of seaweed, make sure they keep their legs together, and that's it. And then another thing that I have found very interesting is that once we suture, we don't ever check again. Like all the preceptors that I have worked with, I have never seen them, like at week 4 or week 6 or whatever, check to make sure everything is okay. And I'm still trying to decide how I feel about that. Maybe it's my medical mindset, working with the doctors. They always checked. They didn't need any excuse. But I don't know. I would ask about it more. And maybe that's just speaking from experience. Nobody ever talked about my sutures and I had problems. And I think that I would ask clients more about, how does your perineal feel? How are the sutures? Have they dissolved? Do you want me to do an exam? Are you okay with how they are? Do you want me to take a look and make sure everything's healing fine? That's something that I would talk about, or at least bring up. And I've noticed that the midwives that I work with, they don't. Oh yeah, so I was going to talk about the anchor stitch. So the anchor stitch is placed 1 centimeter above the internal apex of the tear, or the tear starts. And then usually once you do your anchor stitch, you do a square knot, which I think mine just came undone. Oops. And then check to make sure that it's tight, but not so tight like you can still move it. And then depending on how deep the tear is, you would insert your needle in one side and then bring it up the other side, and the stitches have to be about 1 centimeter apart. And you don't need to sew all the way to the mouth of the vagina. It's better to leave a little bit leeway between the last stitch and then where the vaginal mucosa meets the perineal skin. And then I've also seen where sometimes they'll switch sutures. Like if there's 2 tears and one is in the muscle, like a 2nd degree tear that's at the bottom, that's more inside the muscles, and the other one is like on a little bit on the vaginal lip, on the labia, then my preceptor has used 2 separate sutures. But otherwise, they usually stick with one, and it's long enough that they only need one. I personally have never done a stitch on a person before. I've practiced on foam, on bananas, on chickens. The preceptor that I work with, one of them is an older lady, and she is very artistic. I don't even know how to say it. She's like super artistic. And the way that she sutures, like it'll be a flap that'll be like this, and she'll totally somehow, by the time she's done, it totally goes together. So I still have to practice a lot of practice before I can be like that or do like that or not be afraid. But suturing was one of those things that just in general terrifies me. So I'm hoping that with practice and simple things like tying knots over and over and over again, I can even maybe start with tying a knot and then have my preceptor do the whole suturing, and then maybe I can finish off with the last stitch or maybe start off. But that is my goal for my next phase of midwifery school, is to really get into suturing. And my preceptor is very good about, you're on your own, you can do this, I can talk you through it. It's just a fear of my own that I have.